Hey guys, a very good evening. Hope I'm audible and visible. Let's get the final but one push from Medit side for the FMG exams. So I'm sure you must have gone through all the predictor series of other subjects as well. So now we'll start with pathology as well. We'll have a quick discussion of about 50 questions. Here I'm not going to talk about the concepts. The idea is simple: how to approach a question when it comes in exam. Dissect it point by point so that even if it's a topic which you have not read, there's a most likely chance you can get the right answer, right? We'll have one more thing called FMG marathon, which will be coming before the exam, and we'll make sure that every student who's with us should clear this exam, right? That's the goal, right? Hi Rahul, good evening. Fine. Okay. So I'll be displaying a question. All the questions are from the FMG Predictor book. I'm sure you know the answer, but still I want you to read the question. It's an image, look at the image and type the right answer. The moment we know the right answer, I'll just tell you how to approach the question. What are the keywords? If you have the book with you, I want you to underline the keyword and write the exact points what I'm writing in the board so that it's easy for you to go through before a week before the exam. Fine. Let's go. What's the answer? Answer? Rahul, Mohan Kumar, answer. Another answer. It's a very simple question. The answer is nothing but Burkitt's lymphoma, right? Perfect. So here, this does not actually look like a starry sky. Not like a starry sky, what you must have usually gone through. If you Google, you will see the classical starry sky picture. That's not what you see here, right? But this is definitely starry sky. I'll explain to you what it is. Before that, the keyword which I want you to underline in your notebook is this: a 5-year-old. People generally don't go with the age. If it's a leukemia or a lymphoma, I want you to first look at the age. Child leukemia, ALL, child lymphoma, Burkitt's. No questions asked. That's all. That's how it is, right? It's very, very simple. It's a child with a leukemia. Undoubtedly, it is a ALL. Child with a lymphoma, undoubtedly is Burkitt. I'm not even going to the next part at all. That's all, right? It's very, very simple. Please remember that. Never forget that. Then obviously you have the rapidly enlarging mass, painless swelling in the jaw. Jaw is the most common part of Burkitt's lymphoma. I'm sure you know that as well, right? Right? Then you have anemia is there, everything is there, and the biopsy being performed. This is the classical statistic appearance. If you look at this appearance, what you can see here is you can see this clear areas. I'm sure you are able to appreciate the clear areas here, right? This clear area, the clear areas. These clear areas are the stars of the sky. The stars of the sky is nothing but a macrophages, right? These are stars, empty clear ones, and the tumor cells here are the sky part, right? The bluish tumor cells are the sky part. That's classical diagnostic of a starry sky appearance, right? Generally, the starry sky, what you must have seen is a low power microscopy. Here is bit of a high power, it's completely fine. And if you carefully look, this macrophage has multiple tiny blue things inside them, right? Here also this macrophage has multiple tiny blue things. We call them a tingible body macrophage. If that question comes, tingible body macrophage and macrophage means one and the same. Don't get confused. These are nothing but apoptotic bodies which have been consumed here, right? There are few more things which can come in a Burkitt lymphoma, which I want you to know. Can anyone tell me what virus can result in Burkitt lymphoma? A few more questions with respect to Burkitt's, the virus involved, and I also want you guys to tell me what is the translocation of Burkitt's lymphoma, the common translocation, which also will have the gene involved in Burkitt's lymphoma, and what will happen to Ki67, which is a marker or the proliferation index in case of Burkitt's lymphoma. Everyone. Great going, guys. Everyone has opted for D. That's a good one. The virus is Epstein-Barr virus, right? Perfect, Sanvi. It's an Epstein-Barr virus which is associated with Burkitt's lymphoma. Never forget. And my easy way to remember Burkitt's lymphoma translocation is I'll always remember as Burk8, right? It's not CMV person, it's Epstein-Barr virus. I always remember it as Burk8 lymphoma. It's easy way to remember, right? Easiest mnemonic. Burkitt lymphoma. Burkitt lymphoma means translocation involving 8th chromosome, 814. 14 will be common for almost every lymphoma. So 814 is Burkitt lymphoma, and in 8th chromosome, we have a gene called as CMYC gene, or MYC gene also is good enough, right? Great. 814, 28, 822 are the three translocations, but 814, if you remember, that's enough for me. Ki67, like Mandyam said, it's close to 100%. 100% Ki67 is only tumor which can have 100% Ki67 is Burkitt's lymphoma, fine? This way, we'll be talking about very few points with respect to every question so that we can complete the question and know the approach as well. Okay. Next question. Answer. All these are from your predictor series. I'm sure you must have seen these questions. Which of the following lab finding helps to best differentiate vitamin K deficiency from hemophilia? What do you think is the right answer? A, B, C, D, anything. See, vitamin K deficiency involves all the clotting, your coagulation factors of factor 2, 7, 9, and 10, right? That's what vitamin K deficiency or vitamin K dependent factors are. That's also an important question. We have a few things called as vitamin K dependent factors 2, 7, 9, and 10, which means it involves both the extrinsic, the common pathway and the intrinsic pathway, right? Vitamin K deficiency will involve both common and intrinsic pathway, fine. At the same time, when you say hemophilia A, which is going to be factor 8, which will involve extrinsic pathway alone, okay? So here 2, 7, 9, 10, I have the common pathway involved. When the common pathway is involved, by sure it will increase both PT as well as it will increase APTT. Okay, it will increase both PT and APTT because of 2, 7, 9, 10 involvement. Extrinsic pathway involvement, what will be the only thing which will be elevated? Anyone? In factor 8 involvement of hemophilia, which of the clotting fact or the coagulation test will be elevated? PT or APTT? It will involve only APTT, allow isolated APTT elevation. See, both of them are going to cause coagulation factor defect. 2, 7, 9, 10 and your factor 8, both are coagulation factor defect. In both of them, I'll have problems in clotting time. So clotting time will not help me to differentiate it, right? So platelet count will not, clotting time is not there in the option, bleeding time will not help me to differentiate it, APTT will not help me to differentiate it for the only reason it is elevated in both. Both in vitamin K deficiency and hemophilia, APTT will be elevated, will not help me to differentiate. The only thing will help me to differentiate is prothrombin time or PT, right? PT will help me to differentiate because PT is elevated in vitamin K deficiency and not elevated in case of hemophilia, right? Since we are in this topic of coagulation, I want you to add a few more things which I want you to remember. Last NEET exam had a question based on this concept. APTT getting corrected with vitamin K injection. Remember, if it's getting corrected with the vitamin K injection, that's one of the clues for your vitamin K deficiency, which is generally seen in children, not very often these days because we have supplementation if it's an vitamin K deficiency. It's easy to treat, right? Second, can anyone answer me what's the most common coagulation disorder? You know the answer. This is a repeatedly asked question. And in that most common coagulation disorder, the most common symptom also you'll have to know about it. The most common coagulation disorder is von Willebrand disease. In that, the most common presenting symptom of von Willebrand disease is menorrhagia. Menorrhagia is a place by which most of the von Willebrand disease patients will present with menorrhagia. Fine. Okay. Just few more. Bleeding time and clotting time are something which is not being done these days. They are obsolete. But bleeding time will be elevated in any patients with platelet problem, platelet defect, platelet reduced number, everything. Clotting time will be elevated in any patient with coagulation defect or clotting factor defect. Okay. Just one more. There's a question for you guys. Let's see how many of you can give the right answer. Okay. So there are two platelet function disorders which you know. One is Glanzmann thrombasthenia. The other is Bernard-Solier syndrome. I want you to tell me what is the defect in Glanzmann thrombasthenia and what's the defect in Bernard-Solier. There should be some mutation, right? What's the defect in Glanzmann and what's the defect in Bernard-Solier syndrome? Anyone? Glanzmann defect and Bernard-Solier defect. Glanzmann, you have a defect in glycoprotein 2B3A. Bernard-Solier, you have a defect in glycoprotein 1B9, right? 1B9 defect is Bernard-Solier and glycoprotein 2B3A defect is Glanzmann thrombasthenia. Fine. These are few things which might come in exam. Do remember them. Okay. Next question. A simple and easy one. Let's see how many of you can answer. Mohammad Faisal has gone for C. Others, it's classical Hashimoto, right? So what gives away Hashimoto is the anti-thyroid peroxidase antibody. Please remember, you can have problems of hypothyroidism and your just diffuse goiter subacute thyroiditis, any viral dependent. Sometimes decurine also can have, but it will be a bit painful, right? So you have a history of hypothyroidism. Obviously, here age and gender will not help because most of the thyroid disorders are seen in female. What helps is anti-thyroid peroxidase antibody and this Hurtl cell. Hurtl cell as well as anti-thyroid peroxidase antibody. Option C is the right answer. This hyper. Obviously, papillary carcinoma thyroid will not show antibodies. It's a, what will be the finding in papillary carcinoma thyroid? I want you guys to comment on the finding of papillary carcinoma thyroid. Decurine will be a painful lesion. If you have a painful thyroiditis, I want you to think of decurine thyroiditis. That's important. It will be painful lesion. Most of thyroid lesions are painless. Almost every goiter is painless. If you have a painful thyroid lesion, think of decurines or subacute. Graves is hyper, Hashimoto classical anti-TPO antibodies. And papillary carcinoma thyroid functions. Okay, Sanvi, bleeding disorder, if the question comes, it's about thrombocytopenia, and the most common cause of thrombocytopenia is drug-induced thrombocytopenias. Okay, papillary carcinoma thyroid, you have one classical finding of orphan Annie I nuclei. That's the optical clearing. Orphan Annie I nuclei is very, very classical for papillary carcinoma of thyroid, right? Perfect, great. You'll have papilles, you'll have samoma bodies, coffee bean nuclei. Apart from that, the most important is orphan Annie I nuclei. Okay, perfect. Next question. Simple one, easy to answer by just by looking at the image. Let's see how many of you read the question. Because when you have few highlighted points, we automatically go to that, right? Great, Prasun. BRAF is muted in papillary carcinoma thyroid. You're absolutely right. 33-year-old, painless cervical lymphadenopathy, lymph node biopsy shows classical large binucleated cells, prominent eosinophilic nucleoli, outside appearance. You don't want anything else. The classical diagnosis of an Hodgkin's lymphoma. Whether the image is not there, not that doesn't matter. Actually, this image is very, very dark. This is not how the image should be. Okay. Let's say I'm telling one of the options is, though it is not common, just for an MCQ point of view, one of the options is CMV lymphadenitis. Okay. How will you differentiate CMV lymphadenitis from Hodgkin's lymphoma? If one of the options is CMV lymphadenitis, what will be the answer? Ignore the image. The image is not right. Ignore the image for now. Because you know for a fact, CMV lymphadenitis also, CMV virus also have outside inclusions, right? Right? They also allow outside inclusions. How will you differentiate CMV outside inclusion from outside inclusions of Hodgkin's lymphoma? How will you differentiate that? The best way to differentiate, remember this, Hodgkin's lymphoma also will have binucleate outside. CMV also will have binucleate outside. But generally, CMV will be seen in retinitis or hepatitis. Very, very, very unlikely to see in a lymph node. But if it is seen, Hodgkin's lymphoma will have eosinophilic nucleoli. That's very, very, very important. CMV is a basophilic inclusion. You're exactly right, Sanvi. It is a basophilic inclusion, and Hodgkin's lymphoma is an eosinophilic inclusion, right? Okay, perfect. Look at that. It's eosinophilic nucleoli. If it's eosinophilic nucleoli, I'm going to definitely think of your Hodgkin's lymphoma. Few questions from Hodgkin's lymphoma. Let's see how many of you can get the right answer. We divide them into classical Hodgkin's lymphoma and NLPHL, right? Can anyone tell me the IHC marker for classical Hodgkin's and IHC marker for NLPHL? Exactly right, Shivakumar. IHC for classical Hodgkin's is CD15 positive, 30 positive. The most important is this guy. PAX5 will be weak. Okay. In NLPHL, 15 negative, 30 negative. Instead, I have 20 positive, 45 positive. Again, the most important here is PAX5, which will be strong. PAX5 alone can help me to differentiate whether it's an NLPHL or a classical Hodgkin's lymphoma, right? Okay. So, what's the most common variant of Hodgkin's lymphoma? There's a controversy saying that some books say that this is more common in India, more common abroad. Most common in India as well as in the world, most common by default is nodular sclerosis. Okay. In nodular sclerosis, the Hodgkin's lymphoma variant is called as an lacunar variant of Hodgkin RSL is what we see in case of nodular sclerosis, right? Can anyone tell me what's the name given for the RSL in case of NLPHL? It is a very, very specific name, classical name, which does not look like a popcorn, but you call it a popcorn cell, right? Popcorn shaped RSLs is classical for an NLPHL, right? Perfect. Great. Let's go to the next question. Let's see if we can get the right answer. Read the question, look at the image. If possible, tell the right answer. Otherwise, just attempt. It's completely fine if you make a mistake. These are proper scenario-based questions. Just learning the question also will give you good inputs so that you can remember in the exam for something else. 62-year-old, there's a tumor seen in elderly. Persistent back pain and fatigue. That's the most common symptom here. Bone pain and fatigue because of anemia. Lab reveals elevated serum protein levels. To be specific, globulin levels get elevated. Okay. Bone marrow biopsies has everything written here. Shows plasma cells with eccentric nuclei and everything. What's your most likely diagnosis, right? You can't have more easier question than this. The most likely diagnosis by default, multiple myeloma, right? The goal is not to read multiple myeloma because the question has everything given for us, right? Perinuclear HOF, the eccentric nuclei, everything is given, right? So in multiple myeloma, I'm going to ask few more questions with respect to multiple myeloma. Let's see if you guys can answer. Can anyone tell me one RBC change which is commonly seen in multiple myeloma? I'll give you a clue. It starts with R. One of the classical changes. You see, rouleau formation. Okay, rouleau formation is classically seen in case of multiple myeloma. Not only multiple myeloma, even inflammation will have rouleau. Rouleau is nothing but RBC stacked in the form of a coin. That's a rouleau formation. Something is classically seen in case of a multiple myeloma, right? Perfect. Russell body, Dutchess body, mulberry shape, mott shape cells are all seen in multiple myeloma. True, not denying, right? There are two criteria in multiple myeloma. One is CRAB, other one is SLIM. SLIM is the latest one. SLIM is what we have been following from 2015 onwards, almost 10 years. There's no point reading CRAB, but still people go and keep on repeating CRAB again and again and again, right? Hypercalcemia, R for renal failure, A for anemia, and B for bony lytic lesion on an X-ray. This is an X-ray finding. It's very, very, very old. No one does that. They have stopped using this even before you join medical college, right? SLIM is what is being approved everywhere. More than or equal to 60% cells in bone marrow plasma cells. L is light chain ratio of more than 1:100, involved, uninvolved. If the involved is 100 times more than uninvolved, I'll definitely call it a multiple myeloma. M stands for, in MRI, we have something called focal lesion. Focal lesions in MRI, diagnostic of multiple myeloma. More than one focal lesion is required for us to say it's a patient with multiple myeloma, right? SLIM is what is approved. Agglutination, if you're asking Sanvi, agglutination is seen in case of your cold autoimmune hemolytic anemia. Okay. Perfect. Next question. Let's see if we can answer. We'll see a little bit of more tumor markers along with this. A simple question. 58-year-old with chronic hepatitis B develops a liver mass. The tumor marker most useful for this patient is undoubtedly your alpha fetoprotein, right? Alpha fetoprotein of more than 1000 is directly diagnostic of an hepatocellular carcinoma. Hepatitis B with a liver mass, I will definitely think of an hepatocellular carcinoma only, right? There's no doubt in that, right? I just want you to remember this alone, okay? If any question comes as hepatoma, hepatoma was the older name for hepatocellular carcinoma. Please remember, hepatoma is not hepatic adenoma. It was hepatocellular carcinoma. Because of the confusion, they have removed the term. It's no more existing, but if there's any old examiner, they might ask hepatoma. Hepatoma is equal to hepatocellular carcinoma, right? Now, what I'm going to do is, I'm going to write a few tumor markers. You are going to tell me which tumor you will see them, right? We'll start with the easier one. I'll keep on writing tumor markers. You tell me where do you see them, right? So I want more people to involve, so I'm starting with an easier one. PSA doesn't require anyone to teach you, right? PSA stands for prostate specific antigen. We have CA19-9, CA125, okay. Let's say beta HCG. Few markers have been asked before, that's all. CA 15-3. Tell me, where do you see these markers elevated? Okay. Tell me, alpha fetoprotein, apart from hepatocellular carcinoma, where do you see them? PSA is seen in prostatic carcinoma. CA 19-9 is seen in pancreatic carcinoma. Right, Faisal? It's seen in pancreatic carcinoma. 125 is seen in, very, very important, seen in epithelial ovarian tumors. That is very, very important. Please remember, it's not seen in every ovarian tumors. It's seen only in epithelial ovarian tumors. For example, your mucinous adenocarcinoma, serous adenocarcinoma, it's elevated. Dysgerminoma, not elevated. Teratoma, not elevated. It's seen only in epithelial ovarian tumors, not in every ovarian tumor, right? Beta HCG, classically it's seen in choriocarcinoma. In case of choriocarcinoma, in case of hydatiform mole, it's elevated. 15-3 is elevated in case of breast cancer. AFP, apart from your hepatocellular carcinoma, that's a question. It's also elevated in case of non-seminomatous germ cell tumors of testis and ovary, especially yolk sac tumor. In yolk sac tumor also, it's very much elevated, right? Perfect. There are few MCQs which says that beta HCG is elevated in case of seminoma and dysgerminoma. Partly right, partly wrong. It is elevated in 15% of the case of seminoma, dysgerminoma, not in every case, because those 15% cases has syncytial trophoblast in microscopy with secrete of beta HCG. Fine. Okay. Next question. Tell me what's the right answer. Actually not a pathology question. It's more of a biochemistry question. But let's see. I'm sure Jambulkar sir must have also taught about this. You're right, Sanvi. In proper folding, I require a protein called heat shock proteins. There are multiple heat shock proteins. These are like chaperones. One of the subtype of chaperones is heat shock proteins, right? Chaperones are the one which help in the folding. If the folding is not proper, we result in unfolded folding. That can result in cell death. Just remember, heat shock proteins are the proteins which help in the molecular folding, right? Perfect. Great. Caspases are involved in apoptosis, right? They're not going to be involved in the protein folding. Cyclins are involved in cell cycle, cyclin D, cyclin E, everything. Integrins are involved in rolling addition. At least by eliminating, you'll be able to easily answer answers in heat shock protein. Fine. Okay. The next one. Read the question. Tell me the answer. Again, everything required is already given in the question. If you just read the question, the purpose of predictor book is that it's not just to read the options, memorize the option, go with the explanation. Read the question. Question also gives almost everything required for me. Elderly, anemia, massive splenomegaly. This finding has teardrop cells. That's also an MCQ. Nucleated RBC, an MCQ. Abnormal platelets, an MCQ. And bone marrow's fibrosis. If you look at this bone marrow, the blue structures in bone marrow, all of them are your megakaryocytes. They are abnormal thing. They are all megakaryocytes. Fine. Okay. Perfect. Now, what you see here is all of them are classically elevated in case of an primary myelofibrosis, right? Why A? A is polycythemia, right? Polycythemia will not have these findings, right? Myelofibrosis, the place where you see fibrosis, that's the way to diagnose marrow. And myelofibrosis patients, few key points, they are seen in elderly, RBC finding, teardrop cells, or dacrocytes are classical for myelofibrosis. Never forget that. Can come in an exam. And there's one more peripheral smear finding. This might also come in an exam, which is leukoerythroblastic blood picture. You'll see WBC's precursor and also RBC's precursor. That's nucleated RBC, right? Leukoerythroblastic blood picture. That's classical for myelofibrosis because there's no space in the bone marrow. Everything comes outside. I'll have leukoerythroblastic blood picture, right? And obviously, biopsy of the bone marrow shows increase in fibrosis. And this came long back in an INACT exam. What's a stain? Can anyone answer this? Stain which we use to diagnose fibrosis in the bone marrow. What's stain? Stain is classical stain. We use reticulin or we use Mason's trichrome, right? We use reticulin stain. Reticulin is also a good stain to identify fibrosis. In laser stages, we use Mason's trichrome. There are stains which can help me to identify myelofibrosis. Fine. Can anyone tell me the bone marrow is fibrotic? What will happen to bone marrow aspirate then? The entire bone marrow is fibrotic. So what will be the finding in bone marrow aspirate? Will you see anything, or it will be a dry tap? It will be a dry tap. Before going to the next question, what's the other disease which can have dry tap? Apart from myelofibrosis, there is one important disease which can have dry tap. Aplastic anemia also is dry tap, right? Perfect. Next question. What's the answer? A patient with deep vein thrombosis suddenly develops severe dyspnea and chest pain. The embolus is most likely to lodge in which of the location? The answer is a simple one. If it's from deep vein thrombosis, it can go only to the pulmonary artery, because venous circulation goes to the inferior vena cava, goes to the right side of the heart. From the right side of the heart goes to the pulmonary vessels, and pulmonary arteries or the capillaries is where it can lodge. It cannot lodge in any of the systemic circulation, because it will anyway get blocked in pulmonary capillary. If it's not getting blocked in pulmonary capillary, it will not block anywhere, right? It's a venous thromboembolism. Every venous thromboembolism will go only to the pulmonary circulation, not to the arterial circulation. Atherosclerosis is an arterial thromboembolus. If it can have an atheroembolus, that can go to the renal artery, carotid artery, or coronary artery. Fine. Okay. The next one. Tell me the answer. A simple one, but a little bit of an extrapolation. Let's see if we can identify them. 38 weeks of pregnancy, 32-year-old, poorly controlled diabetes delivers a healthy fetus, healthy infant. Islets of the neonate would expect to demonstrate which are the change. The mother is diabetic. If the mother is diabetic and poorly controlled diabetes or uncontrolled diabetes, obviously the blood sugar, hyperglycemia will go to the baby's blood circulation also, right? Because the baby gets everything from the placenta. If the baby is going to have hyperglycemia, what will be the change in the baby's beta cells? Beta cells will have hyperplasia. A very, very important thing. You might have read this as an important question even in your pediatrics. Because of the hyperplasia of the beta cells, what's the most common complication of infant of diabetic mother? I'm having hyperplasia of the beta cells. So these cells are accustomed to produce more insulin for the last 10 months inside the uterus, right? So what's the complication? The moment baby is born, insulin level will be very, very high. Might cause hypoglycemia. One of the important complications of infant of diabetic mother is hypoglycemia, right? So because of the hyperplasia which happens in the baby's beta cells of islets. Fine. Perfect. Great. Next question. Simple and easy one. Great. 60-year-old acute MI develops hypotension, cool, clammy extremities, pulmonary edema, reduced urine output. What's the most likely shock here? You should not make mistakes in these questions, right? Sometimes questions will be very, very easy in your exam. Don't overthink and make a mistake. Royal Khan. It cannot be neurogenic shock. It's a patient with an MI, right? Sometimes we tend to overthink and write the wrong answer. Please don't do that. Sometimes really questions are easy, not just that how can I ask such an easy question. Don't overthink and write the wrong answer, right? Please don't do that, fine? It's a classical example of a simple cardiogenic shock. Okay, just a simple cardiogenic shock. Fine, perfect. Just only one thing in shock. Your cardiogenic, neurogenic, anaphylactic. Most of the shock will have cold extremities. Okay, mostly the cardiogenic ones, right? Cardiogenic versus and hypovolemic. Hypovolemic is one of the commonest one, right? Will have cold extremities. A septic shock, on the other hand, will have flushed and warm extremities. Because in septic shock, the problem is sepsis, and every sepsis or every infection cause vasodilatation and increased vascular permeability. Because of vasodilatation, initially the extremities will be warm. There's an easier way to differentiate. Septic shock was a hypovolemic shock. The commonest cause of a shock is hypovolemic shock, which can be road traffic accident, hemorrhage, or an uncontrolled vomiting and diarrhea. Fine. Okay. Next. Was the right answer. Since neurogenic anaphylaxis are very rare, we ignore it, Chanvi. 60-year-old presents with painless lymphadenopathy. Biopsy shows follicular lymphoma. Cytogenetics reveals 14-18 translocation. Results of overexpression of which of the following protein? 14-18 translocation, actually chromosome 14, like I said before, is common in every lymphoma which has immunoglobulin heavy chain. Not a contributing factor at all. It's the translocation, that's all, right? Chromosome 18 on the other hand has BCL2. This is asked, this chromosome number was asked before, so do remember. Now tell me, now answer the question. I made it a little bit easier. Now let's see if you can answer the question. Now it's not difficult, right? BCL2 is an anti-apoptotic protein, right? BCL2 is an anti-apoptotic protein which is involved in the inhibition of the intrinsic pathway of apoptosis, right? It's an anti-apoptotic protein. The answer is B here, not C, right? Now let's look at the other options and see if we can find a gene or a mutation and a disease or a lymphoma or any other cancer related to that. Which protein do you think promotes option A, promotes G1 to S phase transition? Which protein promotes G1 to S phase transition? Anyone? G1 to S phase transition is promoted by a protein called as cyclin D1. Can anyone tell me which of the lymphomas cyclin D1 will be mutated or translocated or be abnormal? 14-18 is follicular. You have to know the translocation. You have to know the BCL2. Cyclin D1 is seen in translocation 11-14. 11th chromosome is where you see cyclin D1 and it's seen in mantle cell lymphoma. I always remember mantle like this. MANTLLE. Looks like 11, right? Mantle cell lymphoma. Okay. Next, let's go to option C. Stimulates tyrosine kinase. Tyrosine kinase is a very common finding, right? I'm sure you know that. Tyrosine kinase, you see them in your CML, your BCR, ABL translocation, right? Your translocation between 922. Okay. Option D will not cause a cancer. Enhanced DNA mismatch repair, but actually loss of DNA mismatch repair can cause a cancer. Can anyone tell me in which syndrome DNA mismatch repair will be affected? Which syndrome will have defective DNA mismatch repair? DNA mismatch is classically seen in a defect in the DNA mismatch repair. Is seen in a tumor which causes colonic polyp. A defect in nucleotide exchange repair causes one more disease. This causes Lynch syndrome, hereditary non-polyposis colonic cancer, HNPCC. NER is nucleotide exchange repair, is seen in case of an xeroderma pigmentosa, seen in case of skin tumors. Fine. So I can ask a straightforward question or kind of twist and write the pathogenesis differently. Fine. Okay, next question. What's the right answer? Great. Next question. The question itself has answer in this. What do you think is the right answer? It's nothing but a classical case of a small cell carcinoma of the lung, right? A 62-year-old cough with weight loss, bronchoscopic biopsy shows small hyperchromatic cells, nuclear molding and everything. Apart from these clues, nuclear molding, scan cytoplasm. Do you know any one classical finding in case of small cell carcinoma? Squamous will not have nuclear molding, right? Squamous will have keratin pearls, right? Why squamous? It's not squamous. It is small cell carcinoma of the lung, right? Small hyperchromatic scan cytoplasm, nuclear molding, diagnostic of squamous, small cell carcinoma, not squamous, right? Okay, let's look at any named or important finding in any all of this, right? Adenocarcinoma, there's a variant called an adenocarcinoma in situ, which has a classical finding called an lipidic pattern. You have to remember this pattern, can come in an exam. Otherwise, every adenocarcinoma will have glandular morphology, right? Squamous cell carcinoma, anywhere, wherever you see, will have only one finding in microscopy, which is keratin pearl. Adenocarcinoma marker TTF1 napsin A. Classical marker in case of an adenocarcinoma. Keratin pearl marker for squamous cell carcinoma P40, P63. Small cell carcinoma, we saw like in this question, small hyperchromatic cell nuclear molding. In addition to that, you have a very, very classical finding, that's your Azopardi effect. Do remember them, right? Azopardi effect, that's very, very classical for small cell carcinoma. You will have markers of all the neuroendocrine tumors. Synaptophysin, chromogranin, everything will be positive in small cell carcinoma as well, fine. Large cell does not exist anymore. We have reclassified them as an undifferentiated tumor. We'll ignore it for now, okay? Next. What do you think is the right answer? Actually, there's one more important thing in this question. Answer is simple. Answer is there in the question itself, right? Peripheral lung non-smoker shows gland formation. Just now I said if there's a gland formation and mucin production, it can be only one thing. Vedant, it cannot be A, right? The question says there's a gland formation. If the gland formation, only one of the four options can form gland. Which is that? It has to be option C. It cannot be anything apart from adenocarcinoma because this is the clue here. See, I'm thinking where you're going wrong is everyone is looking at the image. I look at the image, it looks random, weird, I don't understand what it is. Please don't look at the image. For every IBQ, I don't want you to look at the image at all. The moment you look at the image, you're going to make a mistake. Read the question, see if you can solve it. If you can solve it, amazing. Don't even look at the image. Just solve it and go for it, that's all. Gland formation, in addition to that, this is a clue. Peripheral tumor. Adenocarcinoma is a peripheral tumor. Non-smoker. Adenocarcinoma can happen in non-smokers. Very, very classical. Remember both of them. Generally, they are single infiltrative peripheral lesions. Okay. This for lung adenocarcinoma. Lung adenocarcinoma can be seen in non-smokers. Why? Because of the mutation. EGFR is the most common mutation seen in lung adenocarcinoma. Do remember, there's a targeted therapy for this. Siraj sir must have told this because last INST or last FMG had this question. Don't forget that. Apart from that, we can have KRAS mutation and also ALK1 mutation. All these three are important mutations in case of a lung adenocarcinoma. Because of these mutations, it is common even in non-smokers. Fine. Okay. Next question. I am sure you won't make mistakes in this, right? This is image-based question. Classical image-based question. Because there's nothing there in the stem of the question. It's lung biopsy showing a golden brown beaded rod-shaped structure, which is positive on Prussian blue. It's positive on Prussian blue. It's a classical ferruginous bodies. It's positive for iron, right? Prussian blue is iron stain. So ferruginous bodies is classically seen in which condition? It's classically seen in case of, perfect, classically seen in case of asbestosis. The dumbbell-shaped bodies, the ferruginous bodies are classically seen in case of asbestosis. They're asbestos fiber on top of which hemocyanin gets deposited. So we call them ferruginous body and they are pulse post, right? Perfect. What's the answer? Long bone fracture is the clue. And classically after 2 days, it's 1 to 3 days is the time for this disease. After 2 days, develops dyspnea, tachycardia, petechial rash over the chest. Okay. The reason for dyspnea and tachycardia is simple. You have an embolism, which is fat. Actually, it's not the fat, it's the bone marrow's fat. From a femur in an adult will obviously be replaced by fatty tissues. That is the one which gets cut, enters the blood vessel, reaches the lung, blocks everything. It's a classical example of a fat embolism. Very, very classical question of fat embolism. There's a criteria for fat embolism which is there in your orthopedics. Can anyone comment on that if you know? The name criteria, based on that only we have the timeline, the petechial rash, the dyspnea. You can also have confusion because the fat embolus can go and get stuck in the CNS as well. Can anyone tell me the criteria? Let's see if you can tell that. Next question. Criteria for the fat embolism. Starts with G if you want a clue. It's a simple one. No. The criteria name for fat embolism person, Gertz criteria. Okay. And what's the answer for this? Sid, which one Sid for this? Great Gracie. Gertz criteria is the criteria for fat embolism. You must have read in orthopedics. What's the answer for this question? Granuloma and TB is a classical example of type 4 hypersensitivity. You are absolutely right, Sid. It's a classical for a type 4 hypersensitivity reaction, right? How many of you remember its Gertz criteria after I told Gertz criteria? You're right, Sid. You're right. You remember its Gertz criteria after I told Gertz criteria, right? That's actually enough for an entrance exam. You're not going to write a theory exam here, right? Options will have GERD in it. If you can recollect after seeing GERD, that's more than enough. Don't worry. Don't tell to yourself you are bad because you're forgetting things. I can remember once I see it. That's more than enough because option will be there. Answer will be there, right? That's more than enough, right? Okay. The next question. What's the answer? What do you think is the right answer? That's fine, alarms. PSGN. Whether the start of PSGN. Others. C. PSGN again. B. Okay. Fine. So here, I don't expect you to understand the microscopy, especially an image-based question of kidney. It's a bit difficult to understand that, right? If an image-based question is there, first, as I said, don't look at the image. Let's just look at the question. 10-year-old presenting with periorbital edema, cola-colored urine. So it's nephritic or nephrotic? It's a classical case of nephritic syndrome. Can I rule out minimal chain disease? Yes. And membranous? Yes. Because these both are nephrotic syndromes, right? Sure. I'll come to it soon. Fine. These both are nephrotic syndromes. I can rule them out easily, right? And the next line says 2 weeks after sore throat. 2 weeks after sore throat, it cannot be IgA nephropathy, right? This is enough, lag time. You must have definitely seen this. URI, upper respiratory infection or sore throat. Second day, the patient had hematuria. I think of an IgA nephropathy. Second week, the patient has hematuria. I think of an PSGN. This is the classical clue. Without a lag time, if there's an hematuria, you think of an IgA nephropathy, option A. With lag time, you have hematuria. It is undoubtedly PSGN. I have not even gone to the microscopy. Even with the first line, you can solve the question. 10-year-old, cola-colored, 2 weeks hematuria, it's PSGN, unless otherwise proved. That's all. Okay. Now let's come to Ayush's question. See, this image does not have subepithelial deposit. If you read the question carefully, it's written, electron microscopy reveals subepithelial deposit. This is a light microscopic image, right? Here, the only thing what I can see here is, can you appreciate, everyone here, can you appreciate neutrophils here? Can you see neutrophils? Yes or no? Can you see neutrophils? You can see neutrophils. It's a bacterial infection, so you'll have neutrophils. Neutrophils or hypercellularity inside the glomeruli is diagnostic of PSGN. And all these circled one are neutrophils, right? Okay. That's what you see in light microscopy. Subepithelial seen in electron microscopy, not seen in case of a light microscopy. Fine. Ignore that for now. Okay. Perfect. Next question. What's the answer? "40-year-old hemoptysis chronic sinusitis hematuria test is positive for C ANCA. C ANCAs in the brackets written PR3 ANCA. C ANCA is an old terminology, we don't use it. PR3 ANCA is a new terminology. PR3 stands for proteinase 3. Remember that also, okay? Because we report these days as proteinase 3, that is PR3 ANCA only, not C ANCA anymore, right? Okay, now we have different options. We have B, we have D. Okay, let's see who's B and D. So you ignored this, you ignored this. Great. I have a problem with Vaginus or Goodpasture, right? Everyone, can I say Goodpasture's etiology or pathogenesis is antibodies to type 4 collagen? Yes. It's not ANCA mediated, right? Goodpasture will also have hemoptysis. Goodpasture will also have hematuria. That's why you got confused. You're absolutely right in getting confused. But Goodpasture will have antibodies against type 4 collagen or antibodies against the basement membrane. Here the question is not that. Lab test shows positivity for C ANCA. If it is C ANCA, it is undoubtedly a vaginous granulomatosis. Goodpasture, clinical history, Goodpasture will definitely fit in. But here it's antibodies against type 4 collagen. Okay, that's what you see in case of Goodpasture syndrome, not ANCA mediated vasculitis, right? It's antibodies against type 4 collagen. That's classical for your Goodpasture syndrome. Chronic sinusitis, I don't get in Goodpasture syndrome, but hemoptysis can happen in Goodpasture syndrome. Hematuria also can happen in Goodpasture syndrome, right? Perfect. You're right, Almas. You're right. Why will you have hematuria in case of vaginus? Can anyone tell this? Why should there be hematuria in case of vaginous granulomatosis? Anyone? Vaginous granulomatosis as well as microscopic polyangiitis, I can have hematuria because vaginous as well as microscopic polyangiitis actually can cause immune or the type 3 RPGN. One of the classical examples for immune RPGN or type 3 RPGN is vaginous granulomatosis and microscopic polyangiitis. That's why you can see your hematuria there. Fine. Okay. Perfect. Next question. Tell me what's the right answer. Easy one, right? We're not going to discuss much about that. You're right, Almas. RPGN. This is apoptosis. Which pathway is the question? It's mitochondrial. Mitochondria is inside the cell. So it's an intrinsic pathway of activation. Option B is the right answer. Nothing much to discuss. A straightforward question. A feel-good question, so it's the right answer. That's it. Don't make mistakes in this, right? Faisal, it cannot be extrinsic. Mitochondrial mediated activation of caspase is intrinsic pathway of activation, not an extrinsic pathway of activation. Fine. Okay. Extrinsic pathway is your FAS ligand dependent, the death receptor dependent. Fine. Okay. Perfect. Next. What's the answer? "30-year-old present with fever, microangiopathic hemolytic anemia, histiocytes on smear, thrombocytopenia. The patient also exhibits fluctuating neurological confusion. PT, APTT are normal. What's a most likely diagnosis?" A very classical question. I can rule out few things. Answer is TTP. Almas is right. Option B is the right answer. Most of you are right. How do I come to the right answer? First thing, whenever a question says PT, APT normal, I cannot take it as DAC. Right? Completely gone. DAC, everything will be abnormal. Because DAC also can have all the symptoms. Can anyone tell me why not HUS? HUS also can have histiocytes, microangiopathic hemolytic anemia, fever, thrombocytopenia. Why not HUS? ITP, definitely not. ITP is going to present bleeding episode, not thrombus. Why not HUS? The only difference between TTP and HUS, both of them are called as thrombotic microangiopathies. The only difference between TTP and HUS is, in HUS, there will be no neurological symptom. Thus, you are right, history or diarrhea, but not all HUS are diarrhea dependent. I have diarrhea independent HUS also. The only difference is, in HUS, there will be no CNS involvement. If there's no CNS involvement, it's HUS. Both can have renal failure. Both TTP and HUS can have renal failure, right? If CNS is involved, it's undoubtedly TTP. That's the only difference between TTP and HUS. Diarrhea history might contribute, but I have diarrhea plus HUS and diarrhea independent, diarrhea negative HUS. So don't consider that alone. CNS involvement will not be there in HUS, and CNS will be involved in case of an TTP. Right? Perfect. Next question. Not an exact pathology question. Should have been in orthopedics, but still. We feed on other things again and again, right? Simple one. It's a classical sunburst calcification, diagnostic of an osteosarcoma. Osteosarcoma, with respect to pathology, they do have retinoblastoma mutation. Do remember them. Osteosarcoma has one extremely unique genetic problem called as chromothripsis. Okay. Chromothripsis means, thripsy means breaking. What happens in chromothripsis is all the 46 chromosomes will break. The moment all the 46 chromosomes break, they will reunite, they'll rejoin. Okay, they'll completely rejoin, and that is rejoining randomly. That's a classical finding for that's a classical findings in osteosarcoma. Chromothripsis, do remember these two changes genetically in osteosarcoma. Otherwise, it's a complete diagnosis based on radiology and then operate and then treat. Fine. Next. What's the right answer? Answer? Right, Almas. Great. I wouldn't say bimodal thus. You are right. Partly it's called it bimodal, but osteosarcoma is predominantly seen in younger age group. Secondary osteosarcoma due to pages or radiology, radiation can be seen in elderly. Thalassemia. Okay. Let's say I am deleting this option. Deleting this part in the question. I'm not giving serum ferritin at all. What's the answer then? Patient with microcytic hypochromic anemia, serum ferritin is not given. Then what's the answer? Will it change to something else, or will it still say as thalassemia? What do you guys think? The answer is absolutely right. It's thalassemia minor only. But if I change the question, will you think of something else? It will still say as thalassemia minor only, because the most important things are your Menster's index here and HbA2. HbA2 of more than 3.5, you think of thalassemia minor, and Menster's index has been low, right? It's still the same, it remains the same. Remember this. This is a very easy find for you to remember. Thalassemia, right? Less than 13 Menster's index, and RDW also will be less. Okay, that's for classical for thalassemia. It will not change at all. answer will still be the same, right? So, though ferritin helps me in diagnosing it and differentiating from iron deficiency anemia, I have other features also to differentiate from iron deficiency anemia. Answer is Thal minor. And HbA2 will be any day more than 3.5, up to 3.5 to 8% is considered to be in case of thalassemia. Remember that as well. Fine. Ferritin is absolutely increased in case of an anemia of chronic disease, right, Arshad? Fine. Okay. Next question. Before going to the answer here, can anyone tell me what is the disease or what is the name of the thing in question called as? Oh, tell me the answer. Let's discuss later. Great, Gautam. All the best. It's classical case of metastatic or dystrophic. How do you differentiate metastatic versus dystrophic? Anyone? The question is in the name itself, right? Meta means change, right? Metamorphosis is change, right? Metastatic calcification is change in the calcium homeostasis. So in metastatic calcification, calcium levels in the serum will be elevated. That's the most important thing, right? So the only difference here is here serum calcium levels will be elevated. Fine. Dystrophic. Dys means abnormal. Dysphagia, dyspnea, dysmenorrhea, right? This means abnormal. Here, dystrophic is, here there will be abnormality in the tissue. The tissue is abnormal here, but serum calcium is normal here. Here, serum calcium is elevated, but here, tissue is normal here. If you look at the question now, the patient has hyperparathyroidism, so definitely serum calcium will be elevated. And deposition of calcium in the normal gastric mucosa, which means tissue is normal. Undoubtedly, it's a metastatic calcification. I give a history of papillary carcinoma thyroid. Will also have some more bodies. Someone said it's nothing but calcification. Dystrophic or metastatic? What do you guys think? In papillary carcinoma thyroid, dystrophic or metastatic? It is classically dystrophic calcification because papillary carcinoma is abnormal. It's not normal tissue, right? A degenerating tissue like an aortic valve, old age, degeneration, dystrophic. Normal blood vessel, you can have calcification in old age, Monckeberg's arteriosclerosis, dystrophic, right? The tissue is abnormal, degenerating or dead tissue, it is dystrophic. Tissue is normal, elevated serum calcium, it is metastatic calcification. Fine. Okay, perfect. Next question. What's the answer? This question was there in the previous FMG exam. Option C is the right answer. Okay, thus others, what do you think is the right answer? Faisal went for B. Okay, others. Okay, let's read the question. Let's see what will be the right answer. 30-year-old female presenting with infertility, okay, heavy menstrual bleeding, okay, uterine biopsy reveals malignant tumors composed of spindle cells. The moment spindle cells comes, right, fibroadenoma can eliminate, not going to happen in the uterus. Endometrial carcinoma can eliminate because endometrial carcinoma is an adenocarcinoma, right? It's a classical adenocarcinoma, right? Spindle shaped cells. So there are only two possibilities, leiomyoma or a leiomyosarcoma. But also the question is marked atypia. Look at this image. It's also not normal, right? It's atypical. You have mitosis here, right? It's not normal. You have big cells, small cells, multiple atypias there. Marked atypia, frequent mitosis makes it malignant. The only spindle cell malignancy which can happen in this option, 4 options, is leiomyosarcoma, right? Arshad said cigar-shaped nuclei, very, very classical. Very classical for smooth muscle origin. Cigar-shaped nuclei is seen in both leiomyoma and leiomyosarcoma. It's not seen only in leiomyosarcoma, right? Cigar-shaped is a term given for the nuclear appearance, which is diagnostic of smooth muscle tumor, leiomyoma and leiomyosarcomas, right? Why cigar shape? Because the nucleus looks like this with blunt end, looks like a cigar. If you see in Cuban cigar in movies, it has blunt end, right? So looks like a cigar shape, the nucleus. That's a cigar shaped nuclei, diagnostic of an leiomyomas. Fine. Okay, next question. B, C, B. C, B. Okay. Yes, Ashad. Right answer is C, right? Here, if you have identified the right answer after reading histology reveals Schiller dual body and alpha fetoprotein elevated, then I want you to rethink once more. The first word itself is a clue here. 3-year-old testicular or ovarian mass, diagnosis yolk sac. No other tumor comes in a 3-year-old. Less than 10 years old, you can keep it. It is definitely yolk sac. Seminoma happens around 20-30 years. Teratoma happens in the first or second decade. Nothing happens in a 3-year-old apart from yolk sac tumor. Embryonal carcinoma, though it's named embryonal, it has nothing to do with embryology or the age, right? It happens in elderly only, right? A 3-year-old is a clue here. Testicular ovarian, I am going to jump directly to your yolk sac tumor or endodermal sinus tumor. That's the other name for yolk sac tumor, right? So here, this part where you have blood vessels surrounding that you have tumor cells, that's looking like a glomerulus called as a glomeruloid body or Schiller dual bodies. That's a mark. That's an important question as well. Image based as well as one liner. Do remember them. Yolk sac tumors are positive for both alpha fetoprotein and also alpha 1 antitrypsin. Both of them are positive in case of an yolk sac tumor. Two markers, alpha 1 antitrypsin. Age is the clue here. See, don't let the question travel till the last word. Try to eliminate, try to identify the right answer, even the first. Because history solves 90% of your day-to-day patient seeing. So in a scenario-based question, history should solve 90% of the question, right? 3-year-old testicular ovarian mass, I won't think anything else. Rest are all to confirm, that's all. Fine. Next question. What's the answer? Okay, Ashrad. In glioblastoma or any stage 3, stage 4 tumors, what I have is I have endothelial proliferation. Okay, so it's an endothelial proliferation which happens in a high grade CNS tumor, stage 3, stage 4. In some places, it's been mentioned as glomeruloid, but if the term glomeruloid bodies comes, I want to still think of yolk sac tumor only. Fine. Okay, perfect. Where the question says in this question, nuclear chromatin is intact. If the nuclear chromatin is not going to be changed, I won't call it a necrosis. It's nothing but a reversible surgery. As of now, it has not gone to irreversible stage. Fine. Okay. The next question. Momita, why C? Spartan, you need 150 marks, right? Let them say whatever it is. You will crack the exam, that's all. Why you worry about people saying? You give the exam, complete the exam, come in flying colors, tell to your junior, exam is not difficult or easy. If you prepare well, every exam is easy. Again, this question also should be answered in the first line. 6-year-old nephrotic syndrome. I have only one guy. Child nephrotic syndrome, the answer is minimal change disease. And like Das said, they will be steroid responsive, right? 99 to 100% of them will respond to steroid by default, right? 6-year-old nephrotic syndrome, I'm going to think of minimal change disease, nothing else. To add to that, to confirm, I have light microscopy will be normal. Light microscopy will be normal in case of minimal change disease, and your electron microscopy shows effacement of your food process, right? Now, I'll just see if you guys remember this. Can anyone tell me what's a light microscopic change? Any significant light microscopic change which can be seen in minimal chain disease in the proximal convoluted tubules. Glomerulus will be normal in MCD. Okay? Sure, Spartan. Glomerulus will be completely normal in MCD, but in PCT, you'll have lipid deposits. The function of proximal convoluted tubule is resorption. In nephrotic syndrome, I'll have lipiduria. The PCT reabsorbs them, stores them in the PCT. Because of the lipid deposit, we also have one more name called as lipoid nephrosis. Okay? We call them lipoid nephrosis. That's a classical finding seen in case of almost every nephrotic syndrome, classically seen in minimal chain disease as well. Fine? Okay? Perfect. Next one. Spartan, if you have the FMGE Predictor Kit of PW, all these questions are from them. It's just a quick revision of all of them. Okay? That's all. All fat bodies is the urine microscopic finding of the lipid excreted in minimal chain disease. Cell exposed to ionizing radiation. Anything exposed to ionizing radiation, you'll have reactoxin species, which will cause lipid peroxidation of the membrane and your protein denaturation and your DNA damage. The mechanism of injury is simple free radical injury or a reactoxin species mediated damage. Right? Three things: lipid peroxidation, the most common way of damage, protein will be denatured, and you'll have mutations as well, DNA damage. All these three will be caused by reactoxin species. Every single day, every single molecule of glucose your body metabolizes, you'll have reactoxin species. That's why when you eat a lot, you age a lot. When you conserve eating, I'm not saying go on a fasting, starve. When you eat what your body wants, my body will automatically neutralize them because I also have very good amount of antioxidants. Can anyone tell me any antioxidant enzymes which comes to your mind? I don't want vitamin C, vitamin E. No, enzymes. What are the enzymes which comes to your mind if you think of antioxidants? You have catalase. You have superoxide dismutase. But one of the most important guys is glutathione peroxidase. Okay, that's one of the most important thing. Glutathione peroxidase, do remember them. Glutathione peroxidase is very, very important for CNS as well as your RBCs. Okay, that's very, very important for these two conditions. It's important for anywhere, but these two places, glutathione peroxidase is very, very important, right? Perfect. But then, like I said, this is a little bit of a quick revision. We have discussed that in the classes. Do let me know. Just ping me whenever you have time. What is the most difficult part? We'll try to create that in a separate video. Fine. Diagnosis. Yes, that was PYQ. SOD deficiencies can cause amyotrophic lateral sclerosis. It's a classical case of oligodendroglioma, right? CNS tumors, you have to diagnose with the location of the tumor. Dural-based lesion, meningioma. Cerebral hemisphere, I can have oligodendroglioma or a glioblastoma, right? And also the pattern, right? Within Friday is the pattern, right? So glioblastoma, I'm sure you know that it's not glioblastoma multiforme anymore. You have the necrosis. You can call it serpiginous necrosis if you want, plus palisading. Palisading cells with necrosis is glioblastoma. Oligodendroglioma, like we saw, clear cells. We call them a fried egg appearance, where you have cells with clear cytoplasm, classical for oligodendroglioma. Co-deletion of 1p and 19q, that also is classical for oligodendroglioma. In both of them, the most common mutated genus, IDH, isostate dehydrogenase, is the most common mutation for both glioblastoma and your oligodendroglioma. Fine. Okay. Next, you have your meningioma. In meningioma, we have your world appearance samoma bodies. Not all will have samoma, but samoma is classical for it, right? Meningioma, they are positive for the marker called as Vimentin. Both glioblastoma and oligodendroglioma is positive for a marker called as GFAP, glial fibrillary acid protein positive, right? Let's see if anyone can answer the question for this. What will be the microscopic finding for this? Pilocytic astrocytoma. What's the microscopic finding for pilocytic astrocytoma? Anyone? You have a very classical finding. Do let me know. And also tell me what's the finding for medulloblastomas. And also tell me the microscopic finding for schwannomas. Sure, Spandan. Give me a second. PR positive thus, not ER. Progesterone receptor positive for meningiomas. For pilocytic astrocytoma, yes, it's Rosenthal fibers. Classical finding, elongated pink fibers. Medulloblastoma is small round blue cell, or they have a classical finding called carrot-shaped nuclei, tiny elongated nuclei, classical. Along with that, you have homerite rosettes. Schwannoma, you know, Antony A, Antony B, and Verroque bodies. All is a classical finding for schwannomas, right? The main difference between schwannoma and neurofibroma will not have Antony A, Antony B, and Verroque bodies. Only schwannoma will have Antony A, Antony B, and Verroque bodies. Fine. Okay. Perfect. Where is the question? See, Spartan, very easy way to remember. First, differentiate nephrotic and nephritic syndrome. You should know which will be nephrotic, which will be nephritic. Any disease which damages the food process will be nephrotic. Any disease which damages GBM will be nephritic. Membranous is nephrotic. Minimal chain, child with nephrotic syndrome. Crescentic glomerulonephritis or RPGN. When you have a history of creatinine becoming worse, like 2 to 10 or 2 to 8, within a span of 1 or 2 days, 48 hours, it's RPGN. Nothing else required for me. Okay. URI, second day hematuria, IgA nephropathy. URI, 2 weeks later hematuria, PSGN. End stage, GFR is reduced, that's FSGS. And you have hemoptysis plus hematuria. I'll think of an antibodies against your GBM. I'll think of your Goodpasture syndrome. Fine. Okay. Just quick thing. We already discussed that in the first half of the lecture. Later on, please have a look at that. Fine. Okay. Next. We have one more question based on what we discussed. What's the answer? Has crescent. The moment you see crescent compressing the glomeruli in the Bowman space, it's undoubtedly diagnostic of crescentic glomerulonephritis, or like I just said, RPGN, rapidly progressive glomerulonephritis, right? These two, type 2 RPGN, I cannot say exactly with the information given here. Type 2 and type 1 RPGN is based on immunofluorescence finding, right? When you have a history of creatinine becoming like 2 to 8 or 2 to 9, a rapid progress within 48 hours. If the progress happens in 30 days, 1 month, it is not RPGN. RPGN is sudden, rapid. It should not happen in 2 months or 3 months. Sudden progress, I got an RPGN. I have 3 types of RPGN. Type 1, where I have linear immunofluorescence, which is seen in Goodpasture syndrome only. Type 2, rest everything is type 2. Your membranous, your MPGN, your PSGN, rest everything is type 2. Here both granular IF and your mesangial positivity will be type 2. And like we read in the first, type 3 is posse-immune, where it will be negative for immunofluorescence. When it's negative for immunofluorescence, you think of vaginous, we think of vasculitis, vaginous and microscopic polyangiitis. I don't think of a glomerular based disorder, I think of a vascular disorder. We think of those two things, fine. And the reason why we have all of this is break in the basement membrane. That's the electron microscopic finding as well, right? Okay, you write this. Next. Just a way to classify them. Though the word CAN 1, 2 and 3 is not used anymore, we have changed them into two other names. Answer here is CAN 3 because no stromal invasion, right? So we call them HCIL. Your CAN 2 and 3 are HCIL. Other one is LCIL, which is CAN 1. Okay. HCIL stands for high grade squamous intraepithelial lesion. LCIL is low grade squamous intraepithelial lesion, right? Okay. The other name for CAN3 was carcinoma in situ. It's a cancer only, but it's within the membrane, so we call it carcinoma in situ. Fine. Okay. We use these terms because it's easy. I tell a gynecologist LCIL, reversible. They might not opt for a surgery. HCIL, irreversible. I'll definitely go for a radical surgery, not a medical management or a follow-up there. Fine. Okay. Let's see if you can answer this. A very simple question. The entire reason of the FMGE Predictor book is what I found is you guys remember the question a lot. You guys keep on reading the question, you know exactly what's the answer. That's why we put all the information in the question. So that even if you read the question alone and know the answer alone, you can still get good important points there. 12-year-old, a recurrent crisis. That's how sickle cell anemia will present. Pain of the fingers, dactylitis, unexplained abdomen pain, right? We can have pain in the bone, right? Unexplained crisis, vascular crisis is where your sickle cell anemia will present, and also anemia. And peripheral smear, you have this. Sickled RBCs need not always be like this, like a sickle. Flat, upturned, that's all sickle RBCs, right? It's a classical diagnosis of sickle cell anemia. Undoubtedly, the diagnosis of sickle cell anemia, you will never miss that, right? Painful crisis is how they present. They don't present anemia. And can anyone tell me what happens to the spleen here? What do you think happens to the spleen? Normal, abnormal? Spleen might undergo autosplenectomy. Over the period of years, recurrent damage can cause autosplenectomy in case of a sickle cell anemia. Fine. Okay. Perfect. Yes. Drepanocyte is the other name for sickle cell anemia. You're absolutely right. Okay. The next question. This is a fact-based question. It's about an inflammatory mediator. Patient had a fever and neutrophilia because of bacterial infection. Which mediator is responsible for the immediate vasodilatation and vascular permeability in acute inflammation? Interferon gamma, not an acute. It's in chronic, it's in granulomas, right? TGF-beta is helpful in wound healing. Interleukin-2, again, is predominantly lymphotrophic. I don't have any role in acute inflammation due to bacteria, right? It's undoubtedly answer is histamine, right? This is seen in your granuloma formation, right? And TGF-beta is fibrogenic, helps in fibrosis, seen in wound healing. Interleukin-2 attracts lymphocytes. It's a simple one-liner. I'm sure you know the answer. Okay. Next question. Just now we read. Just a follow-up of that only. Inflammatory mediators is one of the tough topic for me. I feel it's tough topic for students as well because it's lots of memory in that. Right? It's simple. Fibrosis is responsible for TGF-beta. TGF-beta and also PDGF. These are two factors which are responsible for fibrosis in any tissue. But the most common is TGF-beta. PDGF is a less important one. Right? At the same time, there is something called as vessels or the vascularity in case of a wound healing. It's brought up by two markers again. One is your VEGF without any doubt. Again, the other one is beta subunit of fibroblast growth factor. Both these will produce neovascularization or increase the vascularity of the blood wound, and scarring is by PDGF and your TGF beta. TGF beta by default is one of the important thing, right? One more important thing I want you to remember with respect to TGF beta, TGF, transforming growth factor beta. The term has growth factor, but this TGF beta is a tumor suppressor gene. You might mistake because of the name as a proto-oncogene. It's a tumor suppressor gene because it promotes fibrosis, not growth of cells, right? It's a tumor suppressor gene, not a proto-oncogene. Even it has growth factor in its name, it's not a proto-oncogene. Do remember that, fine? Okay, next. Spartan, this is not something which can be easily predicted. With the help of the previous exams, most of the systemic pathology are integrated with medicine or surgery or gynecology, right? They're integrated questions. General path, yes, you can have sizable number of questions. Hemat also, considering the last 2 years paper. That's your orphan Annie, right? Classical orphan Annie nuclei. Optical clearing is orphan Annie I nuclei. Not exactly clear, but you can see in few places, even in this image, somewhere you can see the horizontal grooving, kind of like coffee bean. Look at this, look at this. So it's been cut off. I hope you can appreciate this. Kind of like a coffee bean. There's a split in the center, that's like coffee bean, right? Nuclear grooving, optical clearing is diagnostic of papillary carcinoma thyroid. We had discussed about papillary carcinoma thyroid previously itself, fine? Okay. Intranuclear inclusion is seen in FNAC. Okay, now. Can anyone tell me what's the sequence of wound healing here? Correct sequence of wound healing. We know the wound healing steps, right? What will be the right sequence here? First, you'll have inflammation, then you'll have proliferation, then you'll have remodeling, right? Even in this INICT exam, which just got over, proliferation phase of remodeling is where you'll have the angiogenesis and everything. That was one of the options there. So do remember then, inflammation, initial part where the neutrophils comes, removes every debris, throws them away, macrophage comes, cleans the place. The moment macrophage goes away, I start proliferating. That's where the neovascularization happens. Then little bit of fibrosis also happens. Then later on the fibrotic phase, and then you'll have the remodeling phase, right? The right option here is inflammation, proliferation, and remodeling. Option C is the right answer here, right? Okay, perfect. Which of the following is not seen in virtuous triad? Virtuous triad tells us which all can have thrombus, pathological thrombus. After wound, having a thrombus is normal. If it's pathological, in which all conditions we can see virtuous triad, except virtuous triad is three things, right? Endothelial injury, hypercoagulability, and turbulence or stasis. A, B, and C. All these three are components of virtuous triad. An increased platelet per se cannot cause a thrombus formation. That is not a component of virtuous triad, right? So I can have turbulence also as a part. Turbulence or stasis. Both of them are components of virtuous triad. D is not a component of virtuous triad. Do remember them, right? This is the reason why you can have stasis. Long flight journey can have deep vein thrombosis. Lower limb surgery can have deep vein thrombosis. Knee transplant, I need to mobilize early, otherwise I can have deep vein thrombosis. Hypercoagulability, one of the most common mutation in hypercoagulability, this came in exam, is factor V Leiden mutation. It's a mutation which makes factor V resistant to digestion by protein C proteinase. So I'll have more chance of mutation, more chance of thrombus formation. That's one of the most common inherited cause of hypercoagulability. Fine. Okay. Next. The very common scenario, what you can see in ICU. Patient with septic shock develops bleeding from venipuncture sites. This is a very, very, very classical symptom. The patient is admitted, you put a venflon. Normally it will stop after some time, or you take a blood sample, it will stop after some time, but it never stops, keeps on bleeding, is a clue for you to suspect this disease, DIC. It's a very, very important clue. Lab shows prolonged APDT, PT, low fibrogen, thrombocytopenia, elevated D dimer. All of them are classical for only one guy, DIC. It's not von Willebrand, right? It's a classical sign for disseminated intravascular coagulation. The other name for disseminated intravascular coagulation is consumption coagulopathy. We consume everything. The disease consumes the platelets as well as clotting factors, right? That's why I have a problem. I'll have both thrombosis as well as bleeding, right? And the most specific test, these three have been asked. Please listen to the things and read what comes in the exam and write the answer accordingly. Most specific test for DIC is D dimer. D dimer is levels being elevated is more specific. If I have to go to the sensitive test for DIC, I go for a test called an FDP, fibrin degradation products. Well, the question comes as, what's a test which will predict the bleeding tendency of DIC? If the question is on bleeding tendency, my answer changes. D dimer is not bleeding tendency. D dimer is clotting, right? If the question is on bleeding tendency, the answer is the low fibrinogen levels. More lower the fibrinogen is, more chance the patient is going to bleed more, right? All these three have been asked in exam. So please see what they are asking. Don't just blindly write D dimer for everything. Specific test, D dimer. A sensitive test, fibrin degradation product. If the question is, tell me the test which can predict whether the patient will bleed or not, is fibrinogen level. If it's low, patient is going to bleed more for sure. Fine. Okay. That's about DIC. Next. Answer? I just told this also when you discuss it, right? Spartan, great. I'll just answer your question. Just give me a second. Seven-year-old child, ataxia, because it's going to be present in the cerebellum and it's going to destroy the cerebellum. Because of that, I'll have problems in the balance. MRI shows a cerebellar lesion, small round blue cell with a Homerite rosette. This is diagnostic of medulloblastomas classically. Fine. Spartan, you're right. D dimer will be elevated in case of your DVT also. See, you're forgetting the logic behind it. That's why it's difficult for me to place where it is. I told, yes, it's very specific for DIC. What is actually D dimer? Normally, I have a clot like this. Okay, very, very intertwined fibrinous clot. After every clot formation, the clot will lyse. How it will lyse? It will form dimers. That's called as D dimer. So D dimer is an evidence of clot. In DIC, I'll have clot. So D dimer will be elevated. In deep vein thrombosis, I'll have clot. D dimer will be elevated. In pulmonary embolism, I'll have clot. D dimer will be elevated. In any disease where there's a clot present, D dimer will be elevated. Since DIC is also a clot, DIC is a very good test. Fine. Okay. Perfect. Ependymoma will have actually true rosettes as well as perivascular pseudo rosettes. You are right, Das. Okay. Perfect. Okay. The next one. In the predictor book, there are the 4 rosettes. Wherever it is seen, it's there. Do revise them. That can come handy in an exam. We discussed before that in septic shock, I'll have warm extremities. The question is why? Why there is warm extremities in this patient? Thanks, Almas. Warm extremities in septic shock, simple. Sepsis is a systemic inflammation. So there's inflammation, obviously every free radical will be elevated. And here one of the only thing which can fit into free radical is cytokine mediated nitric oxide induce your vasodilatation, right? There's nothing but inflammatory mediator. That's all. Because of inflammation, there's going to be systemic inflammation here. And because of that, I'm going to have warm extremities. Fine. If the same question, I'm going to rephrase them, saying that the patient had a spinal cord damage, or the patient had an anesthetic complication where the spine is destroyed, and the patient ended up having neurogenic shock. Can anyone tell me why there is vasodilatation in neurogenic shock? Because neurogenic shock also will have vasodilatation. Since it's inflammation, this is the right answer. If the same question is on a neurogenic shock, okay, the answer should be loss of vascular tone. When there's a neurogenic shock, like a spinal cord injury, I'll not have sympathetic parasympathetic stimulation. Fine. Okay. So when I don't have sympathetic parasympathetic stimulation, I'll end up in having the vascular tone. I need the vessels to be like this, right? It will be lost. So it will be dilated. Fine. I didn't understand your questions pattern. What is hypertensive 2? No, see, shock is hypotension, right? So when you have pooling of blood, when it's completely dilated outside, you won't have enough volume in the circulation to beat. I'll have tachycardia and hypotension. Fine. Next. What's your answer? Simple question. Long-standing hypertension. See, long-standing hypertension will not have this. It will be a different type of an hypertension. You will tell me the right answer soon. In which hypertension you'll have the classical onion skinning? A long-standing benign hypertension or a abrupt elevation of BP, a hypertension emergency urgency? Where you'll have this? You'll have them in hypertensives, emergency and urgencies in hyperplastic arteriolosclerosis, right? Just give me a second, guys. Just give me a second. I'll come back. Sorry, guys. Okay, this is classically seen in case of an hypertensive malignant arteriosclerosis, right? Hyaline arteriosclerosis is something which is seen in benign hypertension. Fine. Sorry for the glitch. And this is seen in case of an malignant hypertension. Okay. Can anyone tell me what's the gross finding in case of benign and malignant hypertension? The gross finding in case of malignant hypertension, which has been asked before, I am sure you will remember this. Something goes on flea bitten kidney. And gross for benign hypertension is granular contracted kidney. Okay. Again, don't try to memorize them. It's simple. Malignant hypertension, like you guys know, I'm going to have a BP of 190 or 100 millimeter of mercury, right? A very, very, very high blood pressure. Do you think tiny arterioles can manage? No, it will rupture. Flea bitten. It's nothing but petechiae on the surface of the kidney. That's all. Looks like an insect bite. That's a classical thing for your malignant hypertension. Fine. Okay. Next guy. What do you think is the right answer? A localized dilatation involving all three layers of the vessel is called as if it's going to involve the vessel wall, all three layers, I'm going to call it a true aneurysm, right? Actually, when it's a pseudoaneurysm, there's a beautiful image in Robbins, if you've seen that. Normal aneurysm will have localized outpoaching, where this will have all the three layers, your tunica, media, intima, and adventitia. A pseudoaneurysm is actually not an aneurysm. What happens here is there will be a tiny rupture. Because of the rupture, I'll have a blood clot here. A pseudoaneurysm is nothing but an perivascular hematoma. Okay, it's a perivascular hematoma. It's a blood clot seen surrounding the blood vessel, right? It's a perivascular hematoma. It's not actually an aneurysm. That's why we call it a pseudoaneurysm. We see pseudoaneurysm in MI because post MI the heart might rupture. Because of the heart rupture, you might end up in having a tiny amount of blood leakage, which can happen over the period of time, right? That's where you see pseudoaneurysm. And true aneurysm, you can see them in your inflammation. You can see them in your just weakening of the tunica medias in case of your Marfan syndrome, congenital, you can see in multiple places, right? So this is going to be a classical definition of a true aneurysm. Okay. Next guy. What do you think is the right answer? It's a very, very classical image. History is important. 45-year-old, raised intracranial indentation, progressive headaches, and there's a dural base lesion. Like I said before, CNS tumors are always diagnosed based on the location first. A dural base lesion, and if you look at this microscopy, it's full of only one finding. What is finding here? What's the only finding you see here? Entirely filled with samoma bodies. These world blue color structures are called as samoma bodies. This is sammomatous type of a meningioma. We have multiple types of meningioma, and there's a sammomatous type of meningioma. Other four things we know already. We saw a question on oligodendroglioma. You guys only said that Antony B pattern, and medulloblastoma also we saw homoerythrosis, right? Okay, next one. Not a pure pathology question, overlap with microbiology, but still. Defect in which of the following will result in Neisseria infection? Neisseria infection is a defect in the C5 to 9, right? When you have a C5 to 9 deficiency, you might end up in having more risk of Neisseria infection. See, actually, the option A also will cause a disease. Option D also might cause a disease, right? Option A, I'm not sure if you've heard of the disease. The disease causes an hereditary angioedema. That's where you have C1 esterase inhibitor defect, right? Here, this causes hereditary angioedema. Okay. C3 defect, we don't have exactly a disease for C3 defect, but it's a defective complement. It's not specific. You'll have less immunity. You might have recurrent pyogenic infection. Properidin, okay? Properidin actually is an alternate complement pathway. This also might predispose to angioedema a little bit, but do remember, there are evidences properidin abnormality. An abnormal properidin can result in a type of glomerulonephritis called C3 glomerulonephritis or your MPGN type 2. Very, very, very few cases, but if you have to push to some defect, I can call it because C3 glomerulonephritis or an MPGN type 2. And Neisseria, you know, classically, the option C, C5 to 9, the MAC complex is going for Neisseria. Okay. A big question. More the questions are big, the answer will be very simple. What do you think is the answer? So 73-year-old man with episode of hemoptysis, upper GI shows an irregular 4 cm gastric ulceration. Everything is there, irregular glandular collection, everything is there. Through which of the following mechanisms the abnormal gene expression is likely to be occurred here? Okay, Das has gone for A. Might be a bouncer question. Let's see if any one of you can get the right answer. The answer is there in the question, but I want you to read it and understand it. That's all. So I'm talking about a gene. So look at the line where the gene word comes. Molecular analysis shows DNA hypermethylation of the CDKN2 complex, right? The question is has very classically it is highlighted that you have DNA hypermethylation. Now, do you want to change the answer, everyone? I just pointed out which is the important thing here. It is B. DNA hypermethylation. Any methylation will suppress the gene's expression. Acetylation might activate the gene expression. All these are called as epigenetic alteration. What do you mean by epigenetic? Just we'll take a word to understand what is epigenetics. Let's assume this is a gene. Okay? This entire thing is a gene, right? You remember introns and exons, right? Intron will be above the gene, exons will be the coding part of the gene, right? So before that, if I can alter this place, I methylate this place. This methylation will make sure the gene becomes negative, right? That's epigenetics. I don't touch the gene, but I go above the gene and change something. Like you must have remembered Tata box. I can change Tata box to change the expression of the gene. It's not in the gene, it's above the gene. So anything I alter above the gene, not touching the gene, these are called as epigenetic alterations. DNA methylation, DNA acetylation, all these are epigenetic alteration. You remember, if it comes again in exam, do write it, right? Epigenetics questions have been stopped. For past 4-5 years back, there is a crop of questions came of epigenetics. If it repeats, DNA methylation, hypermethylation, acetylation, all of them are epigenetic alteration. They are not gene mutations, fine? Okay, next. We must have definitely read about BRCA. But have you ever seen or thought what is the problem with BRCA? There's one more important clue here. Most of the BRCA1 mutations will be triple negative. What's the right answer? Yes, money, it's silencing. BRCA1 and BRCA2, both of them are a complex called as FAN complex, genes in the FAN complex. Perfect. BRCA1 as well as BRCA2 are actually involved in defective homologous repair mechanism, right? Your BRCA1, BRCA2 forms a complex called as component of FAN complex. FAN complex role is homologous repair mechanism. They involve in chromosomal repair mechanism, right? This is a complex which helps in the chromosomal repair mechanism. So once this is gone, I'll end up in having problems. FAN complex. The same problem where you have Fanconi anemia also. In this complex, apart from FAN, I also have FAN genes or the Fanconi anemia genes. Fanconi anemia also will be problem in the FAN complex. Even in Fanconi anemia, I'll have mismatch, I'll have a homologous repair mechanism defect. That's why stem cells cannot function, they'll die a lot, right? So all these are due to defective homologous repair, be it BRCA1 or BRCA2, right? Few new questions just to make sure we also learn a little bit extra. Next. What's the right answer? Young adult with recurrent hematuria shortly after respiratory infection. I told you twice in the same class about this. Spartan, if you're there, let's see if you can solve this. Renal biopsy shows proliferation with IgA deposition on immunofluorescence. There's any IgA deposit here. What's a likely diagnosis? Can anyone tell me the diagnosis? Everything is there here. It cannot be A. Divya, Sahan, Spartan, it cannot be A. It cannot be A. I have told multiple times, A means it has to have a lag time. It cannot be immediately. Second clue why it's not A. It's classically written mesangium and IgA. It cannot be A. The answer is IgA nephropathy. It's a classical example of an IgA nephropathy, right? The other name for IgA nephropathy is Burkitt disease. I just given the other name. That's how they make the question difficult. They ask the second name so that we forget and we struggle, right? It's a classical example of IgA nephropathy. After URI, if you have a lag time and then you have hematuria, it is PSGN. Within a couple of days, if you have hematuria, it is IgA nephropathy or Burkitt disease. It is not PSGN. Do remember? And it's mesangium. IgA is endothelium, capillary. Here it's mesangium. Fine? Okay. The next guy. Okay. 20-year-old presents the painless testicular mass. Histology shows cells, clear cytoplasm. The reason for clear cytoplasm, that also is a question, is because of abundant deposition of glycogen. They are glycogen rich, that's why it's clear. And in addition to that, the fibrous septa has lymphocytes. Very, very, very classical finding of lymphocytes in the fibrous septa. Fine. Diagnosis is undoubtedly seminoma. If it's a woman, ovary, it's a dysgerminoma. Right. Very classical finding. The markers. I just end with these markers. PLAP was a very, very, very old marker, not used by any of the practicing pathologists. I have much new markers. One, CD117 is positive for seminoma, dysgerminoma. I have OCT3/4, NANOG, which is positive for seminoma, dysgerminoma. The only place this question was asked in is when a FMG exam couple of years back called as SAL4. Actually, SAL4 is a recent marker we use for germ cell tumors that was asked in FMG exam. So don't think that FMG exam is easy, NEET PG is difficult. The level is almost same, right? OCT3/4, NANOG1, SAL4. All these are markers used for germ cell tumors of testis as well as ovary. Do remember them. PLAP is not used anymore. It's a very, very, very old marker. We don't use it anymore. Fine. Okay. Perfect. Great. So you come to the end of the session. We have discussed 50 questions from the FMG Predictor book. The goal of the FMG Predictor Group's pathology session is to make sure you learn the question, the answer, and the image. It will cover most of the required thing in the last few weeks what you can read. Fine. Okay. Thank you guys. Hope your preparations on track. You'll have my other subjects coming in the next week. We'll have an FMG marathon also coming soon. We'll make sure that you will be occupied till your exam so that you'll ace the exam superbly. Fine. Any doubts? Do ping me. I'll try to answer my level best. Fine. Thank you. Thank you for your patient listening, everyone. All the very best for exam. Do well.